Ladies and gentlemen, dear Chairman, thank you for the kind invitation to present at the EBC 2020. I'm going to introduce you in the next 5 minutes to the BIFU.shock-Trial. As we all know, bifurcation lesions, even when moderate or severe calcified, are always a challenging situation in interventional cardiology. If you look at the published data, even when calcium modification tools such as rotational atherectomy is used, the results demonstrated no superiority in comparison to the standard procedure. So there are obviously some limitations coming along with the rotational atherectomy. Some of them are inability to navigate through a tortuous anatomy and severe angled side branches. And we know with rotational atherectomy, multiple wires down while modifying calcium is not possible. And finally, circumferential calcium modification without wire bias is not possible, leaving unmodified areas behind. The question is, can we do better? And for that, intravascular lithotripsy was introduced as calcium modifying tool, coming with a balloon catheter and a generator. The generator produces energy which are applied by the emitters in the balloon catheter. And a small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the sonic pressure waves and then collapses within a few microseconds. When the waves impact the calcium at nearly 50 atmosphere, they create a series of microfractures, and this makes the vessel more compliant. This is an OCT image after lithotripsy showing the nice microfractures of the calcium here in the middle panel. From early studies, we know that the IVL is most effective in long and in death calcified lesions. The safety and efficacy of the system has been proved in the CAD I and II trial, and moreover, we looked a little bit in more detail to the bifurcation subgroup out of these two trials, and in this preliminary analysis, safety and efficacy was confirmed. Therefore, we initiated the BIFU.shock-Trial, which is a randomized controlled open-label multi-center trial in 300 patients with moderate to severe calcified bifurcation lesions intended to treat with a two-stent strategy. After intravascular imaging, the patients are randomized either to standard procedure with NC balloons or to lithotripsy before stent implantation. Key inclusion criteria are clinically relevant calcified coronary bifurcation stenosis according to ACC/HA class 1, 2, 3, Medina class 111 or 110 or 011 as estimated by angiography. Furthermore, there have to be relevant calcification defined as angiographically moderate or severe according to HA definitions. Main exclusion criteria are cardiogenic shock or lesions of the vascular systems or properties that prevent percutaneous transluminal coronary angioplasty or the use of a stent. The primary endpoint is the minimal stent area measured in the side branch. Secondary endpoints are furthermore clinical parameters also evaluated after 12 months. So therefore, I like to conclude, calcified bifurcation lesions are always challenging. We have some treatment options, however, they are limited, and intravascular lithotripsy might be an alternative to other calcium modification therapies. However, randomized trials just as BIFU.shock are needed to clarify its efficacy and safety. Thank you very much.